We move now to the panel discussion element of this afternoon's proceedings, and I have three very esteemed guests here who I'll introduce you to briefly. Plan is around about 25 minutes of questions. I've got some questions to ask, and then we'll have 15 minutes for Q&A. We'll have roving mics. I'll say a bit more about that when the time comes. So many of my fellow panelists will be well known to you, but let me just briefly introduce them to you. Right next to me, Martin Bowles PSM. He's Secretary Federal Department of Health, a position he was appointed to in October 2014. He's currently leading reforms in primary healthcare and mental health service arrangements, access to medical and pharmaceutical benefits, aged care, hospital funding and digital health. Previously, Martin was Secretary of the Department of Immigration and Border Protection, and prior to that, he held positions as Deputy Secretary in the Department of Climate Change and Energy Efficiency and at the Department of Defence. Alongside Martin, Maureen Robinson. Maureen Robinson is General Manager, Clinical Governance, Healthdirect Australia. Maureen's responsible for establishing, directing and managing clinical governance, research and analysis functions at Healthdirect Australia in order to promote and support patient safety and ensure that all Healthdirect Australia services, whether procured or developed and maintained, are clinically safe, effective and appropriate for Australian customers. Prior to joining Healthdirect Australia in 2012, Maureen provided an extensive range of consultancy services in healthcare quality and clinical governance, both in New Zealand and in Australia. And alongside Maureen, Mark Fitzgibbon. Mark Fitzgibbon is Chief Executive Officer and Managing Director of NIB Health Funds. I've just learned he's a Macquarie grad, so go Macquarie. Mark joined NIB Health Funds Limited in October 2002 as Chief Executive Officer and has led NIB through its demutualisation and listing on the ASX in 2007 when he was appointed Managing Director of NIB Holdings Limited. Mark is a Director of various NIB Holdings subsidiaries including NIB Options Worldwide, World Nomads Group Pty Limited. He's currently a Director of Knights Rugby League Limited. Previously, Mark was CEO both of the national and New South Wales peak industry bodies for licensed clubs and has held several CEO positions in local government. So, a very esteemed and learned panel for our topic on health service productivity. So, if I could, I'll direct the first question to you, Martin. Health expenditure is a very significant federal expense. The threat is that will become larger with ageing population, increased expectations and so on, some of the things we talked about earlier. Where we're seeing new and expensive technologies. In which areas across the health sector do you see potential for greater productivity?
Well, thank you, Stephen. Look, let me start that by talking a little bit about what is the health system, because it's not that well understood, even though we all have occasion to use it. We have a pretty good health system in this country, and if you've travelled anywhere around the world and tried to access health services, you would probably know that, but not a lot of us do that. It is the envy of many countries around the world. And look, we spend over $160 billion a year in this country on healthcare, and that's a mix of Commonwealth, state and private sector funding. And if we don't think about it in that way, we actually miss a lot of the picture, because, for instance, 33% of funding activity in this country in health is actually out of the private sector, and not a lot of people really understand that. So if you don't look at the system in total, you actually miss quite a large portion of the system. In a Commonwealth context, I spend about 20% of the Commonwealth budget, so you sort of do come under some scrutiny from time to time. You may have noticed. The way I try to look at this, which gets to this broader economic question, is we are 10% of the economy and 13% of the workforce of the country. And we need to start to think differently, I believe, around healthcare. We need to move past this notion of cost all the time Yes, we need to actually get better, we need to improve productivity, but at the end of the day, we are a large economic driver, and what we do matters to the economy as well as anything else. So what is going to happen from a productivity perspective? Well, I think there is a lot happening already. We've seen some really good work happening around public hospitals, for instance, around nationally efficient pricing. It's actually seen the price component of healthcare drop from around 5.5% to about 1.5% a year. That's a significant change. And that's been driven by this nationally efficient pricing mechanism within that system. Unfortunately, we can't do that right across public and private sectors because the public sector is quite a contained unit, if you like, when you look at it from that economic perspective. Whereas the private sector is different. The hospitals are separate from the insurers, who are separate from the manufacturers, are separate from the doctors, and there's a public hospital component of private as well. So it's quite a complex set of issues. But where next? I think we really don't know what's going to happen in the next 5 years even in healthcare. The world of genomics and precision medicine and what's going to happen with that, and better diagnosis, better understanding, better treatment, therefore better outcomes, is really going to drive a whole range of these debates. It will cost more before it costs less. And I think that's the real dilemma that we have from where I sit most of the time, because everyone's looking at how much we're going to spend. But if you have a look at the technology changes in pharmaceuticals, for instance, dramatic shifts over the last probably 5 to 7, 8 years. The rise of generic medicines, biosimilars, that has changed. It's probably saved the country about $20 billion. So significant shifts because of technology change. If you look at the cost in the health system today, about 65% of the growth in cost is around technology. Most people think it's aged care. Now, obviously, technology gets applied in the aged care context and to people who are ageing, and yes, that plays into it, but technology itself is going to keep driving things. So I think they're areas where we will continue to see economic change. I think we'll see greater cost at one level, but what does that mean in a broader economic sense? We really don't understand as much as we would like to sometimes.
Thank you, Martin. So I'll pose the next question to Mark, if I could. Martin reflected on the fact that the health system is a nexus of private and public sectors. As a representative from the private health sector, where can the private health sector play a greater role in the broader health sector, and what's the rationale for doing so?
Oh, is that for me? I'm sorry. I thought you were next.
No. I'm not taking that one.
Well, maybe if I can drill my way down to that question, because I just want to follow up on some of Martin's thought. There's a wonderful article I read a few years ago now, I think it was in The Economist or something like that, and it set the scene. It's 1980, Jimmy Carter's in the White House, and this particular day the White House is in a state of consternation, total panic, the government's going to go broke, the country's going to go broke, and of course the crisis of the day is US spending on healthcare just hit 10% of GDP. And of course today it's closer to 20% of GDP, and if you believe the Centre of Medicaid and Medicare in the US, it'll be 25% of GDP by 2030. So the reality check is, notwithstanding the important cause of improving productivity, we're going to continue to spend more on our healthcare, and somehow we need to get used to that idea and get the public used to the idea as well. We will move to, and if some dystopian future society spends 90% of its economy on healthcare because it's met all its other needs in society, that's fine. The real questions become, if we are going to spend GDP plus 2% more on our healthcare for the next 1,000 years, the real questions are, how do we fund it? Our heavy reliance on taxation is coming to an end because of an increasing dependency ratio, so inevitably you must shift funding responsibility to the private sector, read individuals. The second question is, what are we actually prepared to trade off? fund our insatiable demand for more and more healthcare. And thirdly, and this is getting to the point, Stephen, sorry to go get to it via Melbourne, but what level of technical efficiency are we prepared to tolerate? So the first two questions are really around allocated efficiency, the third question is around technical efficiency. Because we do see, despite, and I agree with Mark, we have a wonderful world-class healthcare system, but it doesn't excuse the naked inefficiencies that we see in the system. And one only has to read the report released last week by the Australian Council of Quality and Safety in Healthcare, their biennial atlas, to get a very clear view about the extent of over-servicing, under-servicing, which has real equity implications, and just pure good old-fashioned inefficiency. Your chances of having a knee replaced in Hawkesbury in New South Wales is 4 times higher than your chances of having it replaced in Darwin. Your chances of having hysterectomy in Ballarat are 6 times higher than your chances of having hysterectomy in Maitland. What? Why? And so you reflect on that. So what is possibly at the and pull me up. I'm going too long.
No, go.
Yeah. Well, you ask yourself, what is at the heart of this inefficiency? And there's 2 good old-fashioned economic axioms. One is information symmetry. Basically, we're very ordinary purchasers of healthcare because we simply don't have the same level of information and therefore power of the sellers. And the second one is good old-fashioned moral hazard. Funding healthcare through indemnity, whether it be a social insurance scheme, as Medicare is, or a private scheme such as NIB or HCF is. My friends over there. No heckling, please. It used to suit our spending on healthcare because the vast majority of healthcare spending was non-discretionary, associated communicable diseases and whatnot. As what we're seeing with healthcare spending, it's shifting away from non-discretionary to discretionary, like we have our knee replaced at 40 to maintain our single-digit golf handicap. In the old days, it only happened if maybe you're 80 and you're crippled and couldn't walk. So we've got to think about, in light of those two restraints, how do we get information to consumers in a way which helps them make better decisions around their treatment, choice of treatment and choice of doctor? And how do we think about how we finance future healthcare spending to make sure that we mitigate the obvious moral hazard we see in the scheme? And of course, I see the private sector playing a leading role in tackling those challenges, and maybe that's an answer for a question further on.
Yeah, thank you, Mark. So now question to Maureen on inefficiency and on provision. Healthdirect's all about delivering telehealth and digital health services to all Australians. Could you talk to the benefits of technology-enabled digital health services, particularly given your role, how telehealth and digital health services are delivered without compromising safety, effectiveness, appropriateness for customers?
Sure. First of all, I'd just like to explain the scope of telehealth, because I'm not sure that everybody, just as you needed to explain the health system, understand just how broad telehealth actually is. The World Health Organisation has defined it as the provision of health services at a distance using various information and communications technologies, with the keyword being at a distance. So this encompasses telemedicine, teletriage, monitoring, coaching, providing support services, anything really from providing basic healthcare information right through to specialist diagnostics and treatment. So it can cover the whole scope of things. And the media that are used to deliver these are also very broad. So we've got telephone, video, mobile, satellite. We've got social media channels and all sorts of digital channels as well. And who knows what we're going to be using next week. It's almost changing daily. The benefits are many. I'm not going to go into every single one of them. I just wanted to raise 3 benefits with you of telehealth services. Firstly, telehealth allows some populations to actually get medical care or to get health services that they otherwise would not be able to receive. So it provides great access. Just as a matter of interest, modern telehealth, telehealth actually started way back with Alexander Graham Bell, who called his mate and said, "Can you come and help me? I've burnt myself." That was the first encounter of telehealth. But the modern telehealth as we know it today actually started way back in the 70s, when there were 4 sort of industries or organisations that needed to provide health services to their employees at a distance, where conventional models of care either didn't allow them to be provided in that way, didn't provide a solution, or the solutions were far too expensive. This was like NASA and the American military when they were providing healthcare services to people in Vietnam, the Arctic explorers, and also the offshore oil rigs. So they needed to work out ways of providing healthcare to these people, hence telehealth. We at Healthdirect Australia provide the after-hours GP helpline service, which is a telephone service, and we focus this into rural and remote areas where there is actually no GP service in the after-hours period. So these people benefit greatly, these communities benefit greatly from having a GP service provided to them by telehealth means. And it's also great for the GPs who do work out there, but they can't work 24 hours a day. Which brings me then to the second benefit of telehealth services, which is the benefit to society. Put simply, people who live in rural and remote areas need to travel and to go to get health services in the big smoke quite often. And this prevents them from having to be taken away from their communities and dislocated, spending days and sometimes even weeks getting health services in the big smoke. So telehealth allows them not to be dislocated from their communities. This is especially important to Aboriginal and Torres Strait Islander communities. If you only consider the cost of travel and accommodation, then there are big cost savings and cost benefits to be gained from providing these services via telehealth means. The third benefit, which I'll briefly mention, which is pertinent to today's discussions, is the improvement that can be gained in productivity. Now, just consider, for example, that in a GP or, say, an intensive care setting, there's a 1-to-1 ratio of care delivery. In a ward setting, you've got a 1-to-few ratio. In a lot of telehealth services, you have a 1-to-very-many ratio of delivery. And even in some, that's sort of, for example, the nurse triage service that we provide. But in some digital services, like an online symptom checker, for example, which provides great benefit to people, you can provide that with a none to hundreds ratio. So we can get great productivity out of that. Now, this is not to say that telehealth can cover everything and that there's no need for face-to-face services. There definitely is. There always will be. Just in respect to your question about safety and effectiveness and appropriateness, telehealth services are no different from any other health provision. It is absolutely essential to have a very good clinical governance framework in place to ensure that all those services are clinically safe and sound. It's not rocket science, it's not difficult, but you do have to have good mechanisms in place for doing that. And with very little variation, it's not any different from providing any other health services.
Thank you. A question I think perhaps each of you would have something to speak to. Alan raised in his introductory remarks the role potentially of competition as a driver or something that would encourage productivity enhancement. And Mark, in his initial remarks, spoke about information. I wonder whether each of you would take a couple of minutes to reflect on your perspective on what the potential role of consumer choice, of competition, facilitated by greater access to information, might be in bringing about greater productivity in health services. Perhaps if we start with you, Martin.
Thanks, Stephen. Competition in my space doesn't always go well together, but I think I'll pick up on the data issue because I think if we can get data transparency in the system, where a patient who goes to their GP and needs a hip replacement, they understand the cost, quality and safety and clinical outcome data, and they can make a choice around whether they do need it or don't need it, because there are a whole lot of procedures that happen in this country and every country that are not needed. So if we could even get that data transparency, and Mark touched a bit on that as well, I think that would shift the conversation quite a bit. Competition more broadly, I think we have a universal health system that basically where no one will be left behind, if you like. But we also have this very complex mix of public and private, which already builds some level of competition in there. I think the best way to look at how do we drive productivity in that context, though, is make the information available. And if you make the information available, which we have been very poor at in this country, I think we can actually shift the dial. If you look at, and Mark touched on the Atlas of Healthcare Variation released by the Safety and Quality Commission last week. I think it was last week because I did it. But it does say some, reasonably scary things around appropriateness of care from time to time. And if you can have, 16-fold variation in care, and Mark talked about hysterectomy between two places. If you look at hysterectomy variation, it's 16-fold variation. That's quite staggering.
I took out the outliers.
Yeah. But
And
even if
that's
you...
just in Sydney.
And that...
Yeah, North Shore compared with Central Sydney.
It is a staggering statistic.
Yeah.
And if you go back to the first Atlas of clinical variation, it looked at things like some of the scope work. There are some suburbs that probably are 70-fold different to other suburbs. And, you just don't want to stand still in those suburbs because something might happen. It is a scary thought. But the good thing is we're starting to get that information out there now, that at least there is a conversation. But for me, until we actually get it at a patient or a consumer level, we're probably not going to get there. And, it's getting better, and Mark can talk about his white coat, and there's other variations on that theme as well, where we're starting to do that, but we've got a hell of a long road to go, I think.
Mm-hmm. Maureen, Mark, information, competition, productivity?
Yeah, sure. Look, I'm not sure. I get a bit concerned when we talk or become overzealous about free markets in everything. We're not buying potatoes here. We're buying health services. And there are people in the middle of this. We need to be very careful, I think, about the huge imbalance in information that's available to consumers and then their ability to be able to read that information. Health professionals will almost always have more and better information than what we can give consumers. But that aside, I think that one of the most innovative components of the NDIS and the aged care reforms that are going on at the moment is this idea of client-held funds. This is the case with the Choices program in aged care. I think that this could really be a game changer in relation to how clients or patients decide what services they need. This could work, for example, for people with chronic diseases. They could be given a budget to purchase their own health services. They get primary care services, social care services even, all for themselves, and it's going to give them a lot more ability to be able to manage their own health care. Clearly, we can't allocate the whole budget in this way. We still have to save services funding for hospital care. So I think we should take the step and let the consumers decide. The rhetoric these days is about consumer empowerment, co-design, co-production, use of community assets. Shouldn't we be encouraging consumers to have more of a role in decisions about their own care? I recently went to had the privilege of going to the British Medical Journal Conference on Quality in Healthcare in London, and there were many, many consumer speakers who got up and appealed to the healthcare professionals to give them the power to manage their own disease and their own conditions. The whole notion of social prescribing is taking off overseas, and something that perhaps we could consider here. And giving consumers the budget for this. Social prescribing is about giving general practitioners and other primary care providers the ability to prescribe and refer to social services and local and non-clinical type services. And this is all based on the fact that people's health is very much dependent on a number of social, economic and environmental factors. And so this gives them the ability to be able to decide for themselves and look after themselves far more, and it actually does reduce the number of admissions by doing this. These sort of social services I'm talking about are, healthy eating programs and gardening programs and even art activities and things like that. But they're more social programs, and I think that we should be considering that in Australia. Give the consumers the budget and let them go and decide. Mm-hmm. There you go, there's one for you.
Hawke and Keating took all the credit for competition policy, but of course it was Fred Hilmer who really inculcated the notion of third-party access and contestability into Australian marketplaces. And so contestability and third-party access is actually lacking in the the public side of the healthcare system. I should be able to go to Martin and say, Martin, all that money you're going to spend on Tom next year, who's 85 and very sick, at least give Tom the choice as to whether or not give the money to me, and I'll manage Tom and that state money, and I'll manage Tom in a way which hopefully, because I'm a single funder, interested in outcomes and efficiency, I'll do that better. So that's the voucher system that you're talking about. And we really do. Look, people hate American examples, but Medicare Select is in the US is such an example where a person can elect to take a capitation payment, which they then use to buy insurance from a provider who takes care of their total health needs. So we do need to break down the monopoly, which is effectively Medicare funding. Medicare is a Soviet-style monopoly social insurance scheme, as is state funding. So, and with that, hopefully we can get more integrated care as well, because all of us have a little bit of skin in the game. While all of us have a little bit of skin in the game, nobody's going to take ultimate ownership and accountability for the end result. And I know you hate the potato example. But the reality of it is, if I'm buying potatoes, I want to know what I'm paying, and I want to know what quality the potatoes are. And at the moment, consumers are clueless in trying to make comparisons around prices and especially performance. But of course, the digital age is rapidly changing that. There was a time where we simply couldn't collect, assemble and publish the data associated with cost and performance like we can today. If the digital age is fundamentally doing one thing, it is through information shifting power from the sellers of goods and services to the buyers of goods and services. And it's certainly incumbent on us as people who operate in this market to start getting busy and doing that, so I can show Mary or Joe the relative cost of seeing a doctor and the relative performance. And we're very excited, for example, about this idea of producing patient-reported outcome measures, or PROMs. The world's learning how to do this properly, risk-adjusted, et cetera, because we know sometimes the best doctors can see the sickest people, but you can adjust for that. And so consumers, if they are going to pay a huge out-of-pocket to some rock star surgeon, of course she has a rock star reputation, fine, if they want to pay the extra price based upon the quality metrics that we're able to make available to them. But at the moment, too many patients are making decisions around that without any real data or information about the cost and the additional value they may be getting. So data and transparency is going to have an enormous role to play in driving competition, but competition's not the goal. Getting a result for the patient and consumer is a goal, but the ecosystem will become much more competitive.
Thank you. Right, so I think it's about time we invited the audience to participate in the discussion. We have 2 roaming microphones. If you have a roaming microphone, could you wave it in the air? Okay, there's one over there and there's one over there. Let's just invite folks to raise their questions. If you could please say who you are and keep questions brief. No speeches, just questions, please.
Okay. I'm not sure if this is on, but Sturt Eastwood from Diabetes. I might address the question to Mark, just because you mentioned allocational efficiency. So we talk about productivity, but there's been no discussion around the concept of prevention and money spent on, if you like, sickness prevention as opposed to just more efficiency in the Band-Aid solutions.
Well, so certainly I think prevention's an enormous opportunity, something which restricts logical investment in prevention is the multi-funder model that we have. In other words, a dollar, I invest to say, let's say $2, the dollar I save is actually spread between me, the state public hospital system, and Medicare. So, I'm a big believer in creating a single funder system in a way I've described. And I'm a big believer in the medical home concept, whereby you have a much more integrated, coordinated approach to caring, for people to prevent the avoidable hospitalisations and unnecessary healthcare cost. We know that variation we see in knee replacements. We know that we can do much better in avoiding unnecessary knee replacements by a more multidiscipline coordinated approach, physiotherapy, weight loss, etc. But again, there's just too little, not baked into the system yet, and credit to the Commonwealth for trying to fix this with the healthcare home concept. We just don't have the level of integration in the system and funding integration necessary, I think, to really, drive that.
Question over here to the right.
Yeah, hi, my name is Matthew Hingerty from Barton Deakin Government Relations, but I've also in the past been involved in various efforts to establish a medical tourism industry for Australia. This debate and debates like it always seem to me to be happening with a slight air of unreality. And that unreality is that we're talking about a tight, enclosed, domestic national market. But of course, all marketplaces these days are global. And the higher education system confronted this 25 years ago, where strategically and with effort and with government buy-in, we opened up the higher education system to global markets, to foreign students. And the rest is history. I think the last time I looked, it's worth 20 billion, maybe more, in export income. Simple question is, why shouldn't we not be doing the same in health? Mark made a very wise comment about people accessing new data technology to compare prices. I can tell you, and my colleagues could tell you, that every night we get calls from US insurance companies comparing the cost of their health system, the cost of ours, saying, well, why can't I have a piece of that as well? So the simple question is, why aren't we throwing open the health system more aggressively to foreign markets?
Martin, do you want to tackle that? You seem like the man.
Yeah, no, that definitely seems like me. I'm going to sort of challenge a little bit of that because that's an assumption that a lot of things aren't happening in that space. And in the health space, yes. Because in the private sector, it is quite significant export of good quality healthcare in this country. Out of this country, sorry. Generally going into the setup of private health arrangements and sometimes public health arrangements in other countries. And there's some good examples like Ramsay. They do whatever they do overseas. Aspen Medical, just a little company that started out of nothing and is now running hospitals and all sorts of things all across the world. Was in China recently in the aged care sector in China because of the changes of the one-child policy, or because of the one-child policy. They are really struggling in the aged care sector, and there is a whole lot of Australian aged care providers who are pursuing work there. India is the same. On the public side, and it doesn't necessarily go to answer everything that you're saying, but on the public side, I've been absolutely fascinated by the number of countries who are now pursuing us for memorandums of understanding about starting to talk to us and collaborate with us on a range of issues. And some are quite broad and some are quite specific. We have arrangements with China, US, Indonesia, Germany, UK, and the list goes on and on and on. And we are now starting to work in these spaces to see how we can actually contribute in that sense. In our immediate region, the work we're doing in particularly the Pacific, but in Southeast Asia more broadly, and some of that is around as simple as what you'd call health diplomacy, trying to really work out how we can operate or they can operate in their own countries to actually improve healthcare in that space. That is happening to a significant degree. And I think, I've spent a bit of time in education, so I know what you mean by that. I think we're at the start of that process. We've got a way to go, but I think that the preconditions are there now because there are some really good examples. Just another couple of things. What particularly Southeast Asia want is quality. We have it. They know we have it and they want it. You have a look at complementary medicines, absolute classic. Infant formula, another one. Creates all sorts of problems in the Australian market because the other markets are so big. And we've got to remember, we're a population of 24 million and, for instance, China is 1.3 billion. As soon as we shift our focus, we've got to be careful we don't leave our own markets bare. So there's a range of issues we need to contemplate before we really get there.
Other
Can I just add to that quickly?
Yeah, sure, yeah.
You're absolutely right, Matthew. We do about 60,000 hip replacements in this country a year. The Chinese will be doing 60 million in 2030, 60 million. And they're not going to do it in China. They just won't have the resources. So they'll travel, and in 50 years' time, Australia will, because we have a natural comparative advantage in healthcare, Australia will be a major destination for healthcare. So, we can't be... Look, government has to create some appropriate policy settings, of course, but we blame government too much for our problems. What we can, government's not stopping us doing white coat. It hasn't stopped us doing a range of other things. It's just going to require some entrepreneurs who have the guts and the money to build the infrastructure at this end and to go out and market that infrastructure to throughout Southeast Asian. And then there's another question, which is maybe another 30, 50 years away, is what type of healthcare services and products will we be buying into the future? Will it be a hospital? Maybe nobody goes to hospital in 50 years' time because, like on Star Trek, it's done it in some solar-looking bed at home. That's not too far away.
Hi, Ricky Chan, Australian Catholic University. As part of the healthcare supply chain, what do you consider the role of universities in terms of improving efficiencies and productivity?
I don't know who wants to come in on that.
Well, I'll start. The universities play an absolutely vital role, particularly in the workforce issue. And one of the real inhibitors to productivity, particularly in rural and regional, is the maldistribution of our workforce in this country. And we have to come up with some innovative ways of thinking about these things. So if you go back 20 years ago when I was running hospitals, we had major shortages of doctors, and we come up with some inventive ways of actually increasing numbers and doing all sorts of weird and wonderful things. It worked. It worked to the point now where we have an oversupply of doctors but a maldistribution across geography and specialty. So we solved one problem, we created another, or we never really got to the other. And the universities, and I've met with all of the medical deans recently, where we're having this conversation. Because if you think about that in a productivity sense, and your focus is on rural and remote, if people can get better access, if we can get clinicians to that point where you're not going to get everywhere, but if you improve it, you're going to improve the productivity of that community. And I said at the start, we're 10% of the economy, 13% of the workforce. Because I deliberately start to use, health in an economic sense, because we can actually drive the economy. But equally, if we can actually get care closer to patients, and we can actually deal with the issues before they're issues or before they're really issues, we will improve the economic benefit to that community and therefore the country. So I think that's sort of how it has to happen. I think even with all of the things that happen in this space, we are still seeing improved access across the board. It's just slower in regional and remote. And of course, the other impact that has, and that we should really call out, is the impact on our Indigenous population. It is a significant issue, exacerbated if they live in rural and remote. Now, that's not all Indigenous people, but when you put those two things together, you see a major issue. They smoke more, they have more diabetes, they are hospitalised less, they have less cataract operations, they have greater blindness. There's a whole range of things that go in this space. So that's, that's a real challenge for the system, I think.
Time for one more here, I think.
Hi, I'm Scott Taylor, one of the founders of Perks Health, a small health tech startup. One of the questions I had, there's a lot of discussion around data and transparency and greater information empowering consumers and patients as consumers to make the right healthcare decisions and therefore reduce healthcare costs. With the ABS citing that over 50%, if not 60% of Australians have inadequate health literacy, just want to understand what we need to be doing to improve that, or what other strategies we need other than just more information to improve those healthcare outcomes.
So if we're going to provide more information, we need people to understand it and make good decisions with it.
Look, it's not just about providing more information, it's being able to provide it in a way that's understandable, and that is written in such a way that is appropriate for the people who need to understand it. I'll just tell you, because I think this is quite funny, but when we were first set up, which is 10 years ago now, we were given an objective to improve the health literacy of all Australians, which is not the easiest task, and we're still working on it. But we have over 30 million encounters with our services every year, and so we do a whole lot in relation to making sure that our services facilitate greater health literacy in all the people who encounter our services. So we're doing our bit, but it's not about giving them more information. It's about helping them to understand it, and the more they understand it, the more that they can self-care.
Can I just add, I agree with you. I think it is one of the key planks in any long-term reform of the healthcare system is understanding what is actually happening out there. We as a group of healthcare CEOs, so the states, territories and myself, we get together every 2 or 3 months. It's one of the key planks on our agenda now is how do we actually start to deal with health literacy? And I'll go back to what I said earlier. Until we actually get data transparency, we're probably not going to improve it either. So it's a really difficult one.
So just, I'll say 20 years' time to be safe, probably 5.
Next week.
This is giving me content, reliable content, well-researched content, relevant to whatever condition of lifestyle I have. It's starting to produce biometric information for me through implantables, not wearables, forget about that, that'll be old school. Implantables showing me how much sugar I've had today, how many calories I've absorbed. This whole world of biometric information which helps me improve my behaviour. It's when time comes to treatment, it's given me the latest research on the treatment option. Do I really need a hysterectomy, or will...
I would expect you to.
Okay. Or will...
I can be pretty sure of that.
Will endometrial ablation do as good a job? Because one of the reasons that the Australian Quality Commission point to, while there is so much rampant variation, is often the surgeons just don't have access or the knowledge about less invasive procedures. So when we talk about literacy, it's a big universe of information we have to get out there. It's information that even doctors need. If you're a doctor really performing poorly in terms of clinical outcomes, often you don't know. Who tells you? You just keep going, day in, day out, and hopefully the next conference you might learn a little bit. So it's going to give me information on treatment options, it's going to give me information on performance of doctors, it's going to allow me to transact with my doctors, it's going to allow me to be part of a virtual community, again, who are interested in the same things that I'm interested in. It's going to allow me to do patient reviews. Well, we can do this already on white coats. So The digital age, again, I know we keep banging on about it, but it's just going to provide us with that much information literacy, if you like, which completely transforms, hopefully, the system.
And I just might add quickly, it has already started.
It has.
Absolutely started.
Yes.
My health record, for instance, I can access mine from my phone today through an app. It doesn't give me all the information that Mark's talking about, but literally in a matter of very short space of time, it will. It's there, we've got the infancy, we just have to grow it.
I'm afraid time has defeated us, so we'll have to draw the Q&A to a close. If I could please join with me in thanking our marvellous panellists. Thanks.